should get a notification consenting to being recorded. So if you, again, don't want your face shown, just feel free to turn your camera off. People are going to be filtering in. I've just asked if you feel comfortable sharing where you're from, and in the chat, that'd be great. We'd love to see where you're from. So we're going to go ahead and get started, and feel free to use the chat to ask questions. We will be looking at the questions towards the end of the presentation, just because there is a lot of great information. We want to make sure we can get through all of that. So hi, everyone. I'm Rachael Williams. I am the program manager for the Phoenix Center at the Anschutz campus for the University of Colorado. So the Anschutz campus is for our medical graduate and some undergraduate programs. So today we're going to have Loretta Sue join us. She's a forensic program associate nurse manager and also a forensic nurse examiner, also with a PhD student, excuse me, with an interest in IPV and TBI. And she's going to be sharing some of those indications as it relates to intimate partner violence and traumatic brain injuries. So we'll go ahead and get started. Loretta, do you mind switching to the next slide? Thank you. So some of the information that we're going to be discussing today is going to be sensitive. It might trigger some folks, so please take care of yourself. It's not always easy discussing this kind of topic, intimate partner violence. Just know that we are here if you need support afterwards. So email, call, text, whatever you need to do, we're here to chat with you afterwards. Again, take your camera off or take a break, take a little walk if you need that space. Next slide. So some of the things we're going to be discussing today, again, are of a sensitive nature. Keep in mind that I'm one person and Loretta is one person. These are our experiences with this information and with this subject matter. That's not everyone's life experiences, and we understand that. It's also good to keep an open mind here. You might have some questions. Make sure that we're phrasing the questions in a way that is compassionate and obviously sensitive. So you might have questions. I want folks to feel free to ask those questions. You can send a message to me directly or ask after the presentation if you're not comfortable asking right now. And taking accountability for some of that information that we don't know. Loretta is going to be discussing a lot of information that I'm not an expert on. And so I'm here to own up to that and really to move forward in assisting folks. I think it's best that we all understand and learn the information as we're given. Also, it's going to be a little uncomfortable, and that's okay sometimes. So again, lean into that discomfort. Feel free to ask these questions. We're here to learn and grow in a supportive way. Next slide, please. So I just want to show folks, and sorry if the chat is in the way here, just a little bit about who the Phoenix Center is, just a little plug for us so folks know that we are available. This is our lovely room, third floor of Education to North. The south elevators will take you on the third floor right to our office there. So that's what it looks like. I'm the program director. I've been there since September and happy to assist folks. Also being new myself, I'm learning a lot about the campus and ways to expand and increase our support in the CU Anschutz campus. You can also be a volunteer if you're interested. I saw some names of our fabulous volunteers here today. We understand that you're grad students and that you're busy or you're working here and also very busy. So we really work to fulfill your space and the availability that you have. So always open to have folks join us. Could use all the support. And a little bit about us, we do offer confidential services. Those are free. We do one-on-one advocacy-based support. We also create awareness through presentations like this one, as well as presentations to staff and faculty. We are available to any student, staff, and faculty with the CU Anschutz campus. Also working to encourage best practices in the CU community. So I've been working with some folks to build curriculum and also expand on best practices when we're using or speaking about intimate partner violence and interpersonal violence, and really just engaging the CU community through those presentations and building a best supportive community that we can. Next slide, please. So a little bit about today. We are here, obviously. I just told you a little bit about what the Phoenix Center at Anschutz offers. For those folks who are coming in later, I'd love to hear in the chat where you're from. So we're going to talk a little bit about interpersonal violence during the holiday season, and then we're going to discuss the SANE and F&E process. So what happens when someone comes into the ER, or how does this process work? Looking a little bit in that, as well as what occurs during an exam. And then obviously TBI, so traumatic brain injuries and interpersonal violence. All right, next slide. Holidays, they're great for some folks. They're also a time where some people can struggle with that support, and it can be a very isolating time. So I just want folks to be aware of that. They're not always 100% great, like you see on a Lifetime movie. There can be some things that happen within the family unit, that can create situations of violence. And I saw some folks from Blue Bench here. They can maybe correct me if I'm wrong, but recently, I think they have about 160 calls in the month of November, and this month they had over 300. So just obviously creating this awareness that people are struggling in the times of the holidays. So we'll talk a little bit about how do we support someone, whether it be a colleague, friend, family member who might be expressing some concerns to you. And next slide, please. Yes, Lindsay, thank you for confirming that. She said that 78% increase, which that is astronomical. So great that people are getting that support, but obviously the fact that that support is needed right now is speaking a lot to that isolation, I think, component, as well as, and that occurred throughout all of COVID, right? Like here we have an isolated person who's not getting that support and maybe experiencing something within the family unit. So how do we do that? How do we provide support during the holidays? So some survivors may experience additional stress, obviously unique challenges toward the holiday season, where they don't have that support system of like a coworker checking in on them or asking them how they're doing. So some things that we can consider, emotional support. If someone comes to you and they're sharing something or you're noticing something different, how do you approach that? Obviously asking them if they're okay. If someone does feel comfortable sharing something with you, please validate their concerns and their situation. The last thing we want to do is have someone experience a negative effect of a not so great conversation and then shut down and not be open to speaking with folks in the future. So again, validating someone's concerns and asking them what you can do for them. Holidays can be emotionally and physically draining. I think we all know that. Being with your family can be a little bit exhausting sometimes. So just remembering self-care and relaxation, meditating, taking a walk, since it's apparently 65 degrees in the month of December, just taking time for yourself and reaching out to friends and folks when you do feel isolated or you're looking for that support. Safety planning is also really huge. So if someone's in a pretty serious situation and they need some support around how do I get out of that situation? What services and what support can we offer them? So here at Phoenix Center, we can talk through folks about that safety planning, being mindful that you're not telling someone what to do. If someone's not ready to leave their situation or leave their home, don't pressure them into that. That's not what we do here. That's not how we offer the best supportive environment. So with safety planning, we talk about where do you go? What does your daily routine look like? Does that person know what that routine looks like? So how can we switch that up in a way that works for you while keeping you safe? And if you guys have questions about safety planning, that's something that we can walk you through at the Phoenix Center. Next slide. So that's it for Phoenix Center. Again, we're here for you guys on campus. We also love collaborating with other agencies and partnering up. So if you guys have any questions or want to reach out, my email will be at one of the last slides here. So without further ado, I'd love to introduce Loretta Sue. I did not mean for that to rhyme, but she is a forensic nurse examiner, program manager at CU, University Hospital. I think I'm saying that correctly, but thank you, Loretta.
Yes, thank you. Thank you so much for having me, and good afternoon to everyone. Thank you for joining us today. So as Rachel said, I am the Associate Nurse Manager for the Forensic Nurse Examiner program. I'm a Forensic Nurse Examiner, and I'm also in the Nursing PhD program on campus. So I am very happy to speak with you all today about some of my interests, which is forensic nursing and survivors of intimate partner violence and traumatic brain injury. So what is a forensic nurse examiner? We are registered nurses who are specially trained to provide comprehensive care to crime victims and suspects. And that includes conducting a medical forensic exam, evidence collection, and later on, we also provide expert testimony to our patients. And sometimes we provide blind expert testimony about specific topics. We also have training on understanding the trauma response, so neurobiology of trauma, rape trauma syndrome, and battered woman syndrome. And we work with a multidisciplinary response of advocacy, law enforcement, and community resources. To become a forensic nurse, there's a couple of trainings. Here in Colorado, our training is combined adult, adolescent, and pediatric for a 64-hour, but some programs offer them separately. So the adult adolescent is a 40-hour didactic training, and the pediatric is a 24-hour didactic training. And then there's additional trainings on top of that for well visit exams, precepted exams. Each program does it differently, but our program at University of Colorado Hospital, we usually do about 12 to 15 precepted exams for our adult adolescents. We send our nurses to a speculum proficiency at Memorial Hospital with the Sane Safe program for a live model training. We also ask our nurses to do courtroom observation to be prepared for when it's time to testify. And I'm not gonna lie, it can be pretty scary. So it's good to be prepared. We also have additional trainings for the various populations we see. And there's national certifications, which are not mandatory to practice, but it's good to have on your CV. So we have the Sexual Assault Nurse Examiner, Adult, Adolescent, and then the Sexual Assault Nurse Examiner, Pediatric. There is a new certification launching next year through the Academy of Forensic Nursing for a general forensic certification as well. So that's brand new. What is a medical forensic exam? So it's a specialized exam for the purposes of looking for injury and at the same time collecting evidence. Now, not all patients are going to get evidence collected, but we tell patients our exam can be considered evidence. Their documentation and their photos can be used as evidence in an investigation and trial. Each exam is tailored to the patient's specific circumstances. So we don't just have a blanket list of what every patient has to do. It's really depending on what their circumstances are and what they're willing to agree to do. The patient can refuse any portion of the exam. They're not forced to do anything, and they're ultimately in control of any decisions made during the exam. So what's involved with the medical forensic exam? We want to make sure we consent the patient so they know the risks and benefits of doing the exam. There's nothing more important than informed consent. If a patient does not assent or consent to the exam, then we will not do an exam with them. We obtain a detailed history for the purposes of diagnosis and treatment. And part of why that's really important is we have a medical exception to hearsay. So if I just tell a friend about something that happened to me, they cannot testify to that in court because it's hearsay. But because I'm getting their history for the purposes of diagnosis and treatment, I am able to testify about their history in court. We also do a comprehensive head-to-toe assessment for injury and trauma. So it also depends on the patient's history. Where did they say they were harmed? We will look over their whole body with their consent. Sometimes people have injuries they didn't know that they had, but we will do a full assessment depending on their consent. So if a patient says, nothing happened to my lower body, I don't want you to look at it, we won't, but we will educate them on why it might be important. And if they don't want to, they don't have to. For patients who are sexually assaulted, we'll do a detailed anogenital assessment for injury and trauma or pelvic injury. So if somebody was kicked in the groin or anything like that, we will offer a detailed anogenital assessment. We also do a detailed intraoral assessment for strangulation, head trauma, or any oral sexual penetration. And that's that's done using a colposcope, which is a binocular camera, kind of a big well, a couple of ours are kind of big, and it gives us a magnification that you can't otherwise see with the naked eye. So you can look in somebody's mouth, or you can do a pelvic exam and not necessarily see anything with the naked eye. But when you apply that magnification, you could see some pretty detailed injuries. We also document any of their injuries or anything on their body using a digital camera. Even if it's something that didn't occur from the assault, we try to document everything for the purposes of injury documentation. We also use an alternate light source, which is kind of like, we liken it to kind of like a black light. It's not a black light, but it's a flashlight that we use with some lenses, and it helps us see fluorescence or absorption, fluorescence of fluids or absorption of blood for subclinical bruising. Depending on the patient's history, we can also do collection of forensic evidence if the patient consents to. If the patient does not want to have evidence collected, they don't have to do that either. And then discharge instructions are also tailored to the patient's specific circumstances. And I'll go over that more in detail. So the program sees all victims and suspects of violence, whether male or female. And these are the different types of things that we see in our day-to-day. So sexual assault, intimate partner violence, physical assaults, elder abuse, human trafficking, strangulation, gunshot wounds, stab wounds, and auto versus pedestrian. I would have to say, by far, the most common thing we see is a physical assault. And second highest is intimate partner violence. And that is where my interest lies for my population I plan to study for my PhD, and that is why I'm here today to talk to you about this. So what is intimate partner violence? It's any form or combination of physical, sexual, or psychological violence or stalking by either a current or a former intimate partner. So it doesn't even have to be somebody that they're currently involved with. If they've ever had an intimate relationship with this person, it can be considered intimate partner violence. In the US, over 1 in 3 women and 1 in 4 men experienced contact sexual violence, physical violence, and or stalking by an intimate partner during their lifetime. And I find that hugely significant because 1 in 3 women, I mean, we know a lot more than 2 other women if you're a female, or 3 other male men if you're a male. And just to consider this huge impact of 2/3 or 1/3 of the women in your life could have been impacted by intimate partner violence, and 1/4 of the men in your life may have been impacted by intimate partner violence. And then about 1/4 of women and 10% of men experience intimate partner violence with some sort of impact, such as injury, fearfulness, post-traumatic stress disorder, use of victim services, contraction of sexually transmitted diseases. I mean, I could go on. So the amount of impact that IPV can have on patients is really significant. So for IPV and TBI, there's a connection here because about 23 million women may have experienced some sort of head trauma through IPV. And about 11 million women could have experienced some sort of strangulation through IPV. And they're often not mutually exclusive, because when we talk about mechanisms with patients, they may say that they were strangled and then they fell and hit their head during the assault, or they were strangled and they were also punched in the head, or perhaps their head was hit against a wall. So the two often happen together. I'd have to say for our patients, about 2/3 of our IPV patients experience both strangulation and head trauma. So head trauma can cause this direct injury to the head. And then with strangulation, they may experience hypoxia or hypoxic or anoxic injury to the brain. And often repetitive assaults are common. So it's usually not a one-off that these patients are experiencing. They may be experiencing assaults over and over again, which is really concerning because the more you experience this, the worse your outcomes can be. And even though they have different mechanisms of the assault to the brain, it can show similar brain atrophy and neuropsychological outcomes. So cognitive outcomes, how well is their thinking and processing. So what is mild traumatic brain injury? which can also be called concussion. We'll talk mostly about mild traumatic brain injury because moderate and severe brain injury is not as common. So this is a lot of words for one slide, but we're going to go through each of these statements little by little through the next slides. But basically, it's a complex pathophysiological process affecting the brain, induced by these traumatic forces to the head. So what's going on there? This complex pathophysiological process affecting the brain. The brain is a really sensitive organ. And when I talk about strangulation too, having lack of blood flow or lack of air can really affect the brain in terms of if your brain does not have nutrients, the cells start to die. Your brain does not regenerate itself. So it is a very sensitive organ. It's kind of like a highly technical supercomputer. There's 86 billion neurons, 86 billion non-neuronal cells. How many connections are disrupted through these mechanisms to the brain? There's chemical and electrical disruptions and changes, and you have this inflammation that can happen in the brain. So induced by these traumatic biomechanical forces, secondary to direct or indirect forces to the head. So injuries caused by any mechanical forces that can cause, that disrupt brain functioning to the point where signs and symptoms are experienced. And we ask our patients about all the signs and symptoms they could be experiencing after they experience an assault. Mechanical forces can be a bump, a blow, jolt to the head, hit to the body that causes the brain to move rapidly back and forth. So if I wasn't talking to you about this in the context of assault, sometimes we would think about this as a motor vehicle accident, because that is also a common area where you see brain injuries. Forces can cause the brain to bounce or to kind of twist in the skull, which can create these chemical changes in the brain, sometimes stretching or damaging the cells. And when these kinds of forces disrupt this complex structure, it can cause impairment. So the disturbance of the brain function can be related to neurometabolic dysfunction, which is this complex system of cellular and molecular changes that pathophysiology of the brain wants to always be homeostasis, right? It always wants to have this one static phase. And when there's a disruption, it tries to recover itself through these different processes. So overt structural injury is very rare in mild traumatic brain injury. And it's typically associated with normal structural findings. So if you go to the ED, they're probably, if you got a hit to the head and you didn't have certain signs and symptoms that are overtly concerning for like a brain bleed or things like that, they're probably not going to do a CT or an MRI because these kinds of changes are so minute that they're not overtly detected. So it's normal to be normal. For a loss of consciousness, the majority of patients don't lose consciousness for mild traumatic brain injury, but something we have to consider is an alteration in conscious or a change in mental state. So when there is perhaps not, I blacked out, but I saw stars, I felt fuzzy and confused, those are things that I get concerned about. So mild TBI, they can lose consciousness for about 30 minutes, but anything more than 30 minutes and less than 24 hours is a moderate TBI, and anything over 24 hours is a severe TBI. And we don't see those two very often in our intimate partner violence patients. So we look at a constellation of signs and symptoms. Now, every patient who comes to me and says they have a headache, I don't just automatically assume, oh gosh, they have a concussion or a mild traumatic brain injury. It's their history and their signs and symptoms and the constellation of all of those things. So do they have physical symptoms? Most often, headache is reported. Nausea, vomiting, balance, dizziness, visual problems. Now, these things can be explained by certain factors, and sometimes it can just be explained by, getting hit to the head. The cognitive portion, do they feel foggy or slow? Are they having trouble concentrating, difficulty remembering? And emotional. Well, it's hard to not feel emotional after being assaulted by your partner, but this is kind of above and beyond, what are they feeling in the last 24 hours or since they've been, since they were assaulted, if it was within the last 24 hours. So are they more irritable? Are they sad, more emotional, or nervous? If they've had time to sleep, are they sleeping more or less than usual, or do they have trouble falling asleep, or just experiencing drowsiness? So these are all clinical concerns that would lead us to think, oh gosh, we're worried about them having a mild traumatic brain injury or concussion. And some of these symptoms could last just a few minutes. So we usually like to ask them, if you've had any of these symptoms, have they since resolved? And sometimes they haven't. And we educate patients that these symptoms could last for weeks or months or even longer. And when it persists after the immediate stage into a certain amount of time, then it can become chronic post-concussive syndrome. So when we're seeing these patients initially, we have some things that we want to consider, because the sooner we can educate patients on care for a possible mild traumatic brain injury, the better their outcomes could be, because they'll be aware of it and taking care of themselves. So when we see our patients, when a patient says that they've been hit in the head, we do a comprehensive neurological exam. We have some additional photography that we do that includes the cardinal gazes, as well as looking in their mouth with our colposcope. We do a screen called the acute concussion evaluation. It's the heads up screen through the CDC. And then we educate them before they're discharged on signs and symptoms and things that they have to be aware of before they go home. So the next few photos, next few slides, I'm going to show you guys some photos just as a warning. So things that we will see when we're doing our cardinal gazes are petechiae. So if you see my mouse over here in this top left photo, there's a tiny little speck of petechiae in that person's eye around between 3 and 4 o'clock. And then in the lower one, you'll see it in this person's conjunctiva. And then subconjunctival hemorrhage is anything larger than 3 millimeters in the eye. So you'll see that here around 9 o'clock, and then from about 5 to 3 o'clock in this person's eye. Now, before we started using the colposcope for intraoral photos, I personally had a patient who I could tell had significant mouth injuries, and I couldn't get a good photo. This is the best photo I'd gotten of this patient. So you could see that she had some lacerations in her mouth that had been healing, but I couldn't get a great photo of it. So it got me thinking of how can I get a photo that's like magnified and clear and bright and you can really see these injuries. And I started practicing with the colposcope on myself, and I would sit in the suite with the colposcope and the TV, and I would just try to position it in front of my mouth and look at the TV. It was very awkward, but it was a really great experiment, because now we do these photos with all patients. So this is the kind of photo we can get now with that brightened, magnified look. When somebody is hit in the face, you can really see the injuries in their mouth. Other things that you can see are petechiae. So when you're looking, just a quick look with a flashlight in somebody's mouth, you may not see these small little red dots. Petechiae are these burst capillaries. And when you're using the colposcope, you can really truly see the injuries in their mouth. For the acute concussion evaluation, it's got 4 sections that we review. And this gives us an idea of what's the status of their possible concussion and what are their risk factors that we need to keep an eye out for. So we get a history of their injury characteristics, which is, how did the injury occur? What kind of force did they sustain? What kinds of signs and symptoms can we visualize? Did they have amnesia, loss of consciousness, or any seizures? And then we go through the symptom checklist with the patient and say, in the last 24 hours or since the assault, if it was within the last 24 hours, have you been having any of these symptoms? And those are the symptoms that I had listed before, those physical, cognitive, emotional, and sleep symptoms. And we'll go through that, and it generates a score for us. So the score is ranging from 0 to 22. the higher the score means more symptoms that they're having. Now, somebody may have not ever had a concussion before, and their score can be kind of high, and we want them to take some care when they are going home to discharge from the hospital. Now, if somebody has a lot of risk factors for protracted recovery, I'm more concerned, because the more concussions or mild traumatic brain injuries you have, the worse your prognosis is. So if somebody says, yes, I had a concussion when I played soccer in high school and I got in a car accident when I was in my 20s, then I would educate them that your recovery may be a little longer than you would normally anticipate, and here are my recommendations. And then we give them red flags for acute emergency management, because if they are having some serious symptoms that are concerning, we want them to know when they need to come back to the emergency room. So consideration of long-term outcomes for IPV. Now, this is just general IPV, the first two of these. So they have commonly reported negative impacts. So feeling fearful, fear for their safety, and symptoms of post-traumatic stress disorder. They can have more health consequences. So more total health problems than non-abused women, including gynecological, central nervous system, and chronic stress related. And then they may have more other things like asthma, irritable bowel syndrome, chronic pain, difficulty sleeping, and so on. But studies that have looked at specifically TBI with IPV find that women who have experienced head trauma or strangulation have more central nervous system symptoms compared to other women who have been abused but not experienced head trauma and strangulation, except headaches. Headaches were common all around. And they have more significant mental health consequences, including PTSD and depression. So when somebody experiences head trauma and strangulation, then we usually want them to know, like, you may experience some more health symptoms later on. We want them to be connected with healthcare. We want them to be following up so that they're taking care of themselves. So for the first few days, we tell them rest. Take short breaks from school or work. I can't tell you how many patients I've had that are like, no, I just need to keep myself busy. I want to go back to work. And we're like, well, that's really not a great idea. Like, we want you to rest. But they do want to kind of distract themselves. We will give them a doctor's note for when it's safe to return to work, school, or any other activities they may be involved in. And as they start to feel better, we advise them to gradually return to non-strenuous activities. Avoid activities that make your symptoms worse. So they may need some more rest breaks during recovery for a few weeks. These are the red flags that I had mentioned before. So if they are experiencing any of these symptoms, we give them our concussion discharge instructions and let them know if they experience any of these symptoms, we want them to come back to the emergency department. I have had patients who have come back to the emergency department because the way everyone recovers from mild traumatic brain injury is different. Some patients may bounce back pretty easily and others may not have that, and that could be due to those poor prognosis factors. Then when we are educating our patients for discharge, we want to make sure we cover community resources, because medical is not always the end all be all. As much as we love our patients, we want them to have this comprehensive approach to their care. So we would refer them to victim advocacy for either law enforcement or community agencies. And we tell them that your victim advocate is super important to keep you connected, but also for victim compensation. They can help with that process of victim compensation. We let our patients know that they should not be getting a bill, especially for our sexual assault patients. They should not be getting a bill, but they might get a bill for the physician screening exam and medications. So those are super important to apply for victim compensation, and we'll let them know what the process is through working through with victim advocates to get that process started if they do get a bill. We want them connected for medical follow-up. So our program does see outpatients. If we see them for a forensic exam, we can bring them back for an outpatient visit. But that may not always be feasible for the patient themselves. So we give them recommendations for health clinics that they can follow up with, like Planned Parenthood or Salud Community Health, Stride, counseling, We have a list of counseling services that they can contact. If they need a shelter, our nurses work very diligently to try to get them into a shelter. We refer them to community services depending on what their needs are, and give them the hotlines depending on what type of violence they're experiencing. So let's talk about this case study. A female patient enters the emergency room presenting with the following information. She shared that a few days ago, she was arguing with her boyfriend. He became violent, and she remembers him shoving her against the wall, but can't remember anything else. All she can tell you is that she woke up on the floor. She's not sure how long after the fight this happened. She's having trouble piecing together the events. When she woke, she realized that she had urinated on herself. And since the incident, she has suffered from headaches and memory loss. So let's talk about this. If you guys were her care providers, how would you assess her? What do you think might be some underlying medical concerns, and what questions would you want to ask or other tests you might want to run? So we'll open it up to everyone for participation.
Yeah, feel free to unmute yourself if you're feeling brave, or list in the chat if you have any thoughts about this case study. Ava, hi.
Hey, I thought I would just jump right in. So a care provider, I think first, it's really important that we get her in a room that is private, that's not triggering, do the normal victim advocacy stuff that we love. In terms of underlying medical concerns, the fact that she lost consciousness and she she has urinary incontinence during that episode is concerning. And I think we'd probably need to do a CT scan to see if there was any further injury, bleeds, fractures. If she was unable to do a CT scan, or if she happens to be pregnant, then either doing an X-ray. There's some arguments about whether an X-ray is actually going to be harmful if it's just the head, but an MRI as well.
Great, thank you for that. Now, when I hear urinary incontinence, I always get worried about strangulation, and so things that I would ask this patient too would be where she's having pain. So she's having some memory loss, and that's okay. I may ask her some sensory questions. What kinds of things do you remember feeling, like touching, smelling, anything that you remember seeing? Because our brains, that primate part of our brains, it really responds to sensory questions. So kind of trying to elicit some more of a history by asking about the sensory questions and pain can be really helpful for coming up with some other issues that we may want to look at. Does anyone else have any ideas, any questions or comments?
I always talk with the mute on, like subconsciously muting myself. So I think obviously I have a different lens, and I'm not in the medical industry. I'm in the like victim services industry. So what I think is this is pretty typical that folks will have a hard time remembering what happened after experiencing this kind of trauma. And so the first thing I do is always validate that experience and try to normalize it, because as you explained in your earlier slides, there's obviously going to be some cognitive issues when we're dealing with folks who've experienced this kind of violence. So I always try to normalize that and explain, because I know that that can be a frustrating experience for you not to remember what happened to you. Absolutely. That is a fantastic point. And I think it's important that we do that with all of our patients, because what they're going through is scary. I mean, what this particular patient went through is terrifying. And I always tell patients that I'm really proud of them for taking care of themselves and making sure they're okay. And it's okay to not remember. It's not, if you don't remember, it's not anything, and like any sort of commentary on who they are as a person.
Yeah, I also just want to point out, if this is the ED, I'm up in the Springs right now, and our ED is slammed. And I've encountered quite a few patients that are having PTSD responses from the ED, feeling unsafe, feeling out of control, all the noises. just the hyperarousal that it needs to be in the ED. So I think as a medical student, I get a lot more time with patients, but just running through your head of like, okay, what is life-threatening? If there's nothing life-threatening going on right now, how can I mobilize resources around me so this patient is really heard, is given time to think about their answers, is done in a way that isn't hyper arousing or further fueling this kind of thing. So I would love to take that time as a future MD, but that's not usually the case. So I would probably get a nurse, get someone who can spend a little bit more time and try to investigate that a little bit more. It's helpful when those resources are already in place, but I'm finding that a lot of EDs don't have that in place, at least up here.
Absolutely. I would say if you're in Colorado Springs, I'm guessing you may be at Memorial. I would engage those forensic nurses at Memorial because they are amazing as well. So for hospitals that have a forensic nurse examiner program, we do spend a lot of time with our patients. Doctors may spend 20 minutes with a patient. Our exam is so comprehensive that depending on the type of assault and what the patient needs, our exams can be anywhere from 2 to 6 hours. So it's relying on the forensic nurses to be able to piece that together. Now, a patient may need those things and may say, I don't want to talk to a forensic nurse, and that does happen often. I try to talk to all of my patients, regardless of what they tell the doctor, because we're the experts in our own jobs, right? So we can explain our roles best. And sometimes I agree with the patient. Like, yes, there is time constraints and we can't do a full exam, but maybe we can do the danger assessment, which is a tool that looks at their risk of lethality within the next year. So perhaps they can't do an exam, but they want to do the danger assessment and concussion screening. So I try to offer a bit of my services to all patients, even if they don't want to do a full exam.
I found that my patients, I have to do a lot of education around what does a forensic exam actually entail, and with fellow healthcare professionals as well, is that this is often the first time that you regain some bodily control, that people are listening to what you're saying. So sometimes I just try to frame it as like, hey, forensic nurse examiner, not as scary as it sounds. Ultimately, it's your choice whether you want to move forward with a forensic examination, but I think you could really benefit from talking to them.
Yeah, absolutely. And I try to not tell patients I'm a forensic nurse examiner, because they hear forensic and it can be scary. They think we either work with law enforcement, or perhaps they're going to die because they hear forensic and they think death. So I try to tell people I am a nurse who's specially trained to take care of patients who are affected by violence. So it takes that kind of scary connotation away from it. Because if they don't want to report to law enforcement and it doesn't meet my mandatory reporting requirements, then it's okay. They don't have to report. We'll work with them as best we can. Any other questions or comments?
I was checking the chat and I didn't see any questions or comments related to that, but I do think it's also important that we are creating this space, similar to what Mava said, is someone does disclose something, how are we going to support them when there is all this chaos going around if they are in an emergency room department? And frankly, for me, like, doctor appointments and doctor offices can be intimidating and scary. So how do we create that space for folks to feel vulnerable enough to share additional information that might benefit their safety and their health? And I will just put a plug in for obviously your all's department. You have a great facility where it's just a separate, very quiet space, it's like in the eye of the storm. There's like craziness going on all around you guys, but there's a separate suite where you can take folks and also provide information and materials and really walk them through what intimate partner violence is. And I know that you all also utilize support of other resources like Blue Bench and calling in for advocacy support when a patient expresses they might need that additional support. So I love that you guys do that.
Yeah, we try to be as comprehensive as possible, and we're always up for suggestions.
Yeah.
I wish we had another suite, because what we're experiencing is, sometimes we'll have a patient in the suite already, and then we get another patient and we have to end up seeing them in the emergency department. And that can be hard. We try to prioritize the suite for our sexual assault patients. But sometimes patients aren't always appropriate for the suite. They have to be medically cleared, or they are having some psychiatric issues that may make them or our nurse unsafe. So we decide to not have them in a private, secure space. So, a lot of factors go into considering when to use the suite for some patients.
Yeah. Utilizing those resources that we get. I know all about that.
Yes.
We do have a couple questions in the chat. So going back to one of your earlier slides where we were discussing individuals who have jobs, and you said we can write a letter explaining that that person might not be suitable for coming into work and may need to relax. So what about the folks that aren't able to leave, or they have jobs that don't allow for that space for them to recover? What do you advise, and would victims' compensation protect them at that point?
I am not sure about the victims' compensation protection. I think the victim compensation is pretty limited in terms of the amount of funds they can distribute, and that also depends on the funds that are available per jurisdiction. So I don't know the complete answer to that. In terms of jobs that don't allow them to, that is also sticky, because I can write a note that says, please excuse this person from work, until Sunday. And if they say a doctor's note's not good enough, like I don't have the control over that person's job or their boss to make those decisions. So I can only do the best that I can with what I have. And of course, I would never put in that person's doctor's note like specifics of their injury or their care or anything like that. We keep it very general. It's unfortunate that there are jobs that are not understanding. So I don't know how that is handled in terms of victim compensation.
Well, I was in that world a little bit, so I can answer that one as well. But it's absolutely right. The resources are limited, and it is tricky. So I was working in the criminal justice field for 4 years. And obviously, if you've experienced a lot of trauma and you're in the hospital, you're not going to work, right? Sometimes you don't have that choice of I'm getting up today. So we worked with folks all the time who would get approved by victims' compensation for some funds. They weren't the whole of their funds. It's a sticky process where you have to utilize, they require you to first utilize all of your vacation and sick time, and then also any other resources. So FMLA, anything like that, where you're getting AFLAC, anything where you're getting, but you're not getting the full amount. So you're only getting like 66% of what you make. So yes, is it helpful? Yeah, but is it the best solution? No. Because some folks don't have the ability to go back. So they are slowly getting rid of things like spousal support for DV situations where the primary income person might be incarcerated. So there's things like that that have unfortunately been narrowed down just because of the staggering amount of crimes that occur and the lack of funds. So they do have some resources. I personally know of other resources that are like more nonprofit based or religiously based, that don't have to go through like government stipulations, that can provide certain things that you would never expect. So things like repayment of funds, or well, I lost my hearing aids in this, and how do I get new hearing aids? So yes, they can help, but it's not what it should be, in my opinion.
I mean, we would all love more and more resources to be able to comprehensively help our patients, and unfortunately, it feels like every which way we turn, funds are getting cut in one way or another.
Yeah, and similar to what you said, like Colorado is a right to work state, right? So if someone wanted to fire someone, I'm not saying they don't have like a civil lawsuit later that they can go through, but like it is what it is. You're going to get fired if that employee doesn't understand this kind of trauma.
Yeah.
Ava?
And I just want to point out for that, I find that one of the most damaging things we can do as healthcare professionals is not prepare our patients. And this comes within this conversation, but also beyond, that patients are most frustrated when we tell them something is going to be a certain way and it's not, or we didn't tell them something really important. So either writing it down, if someone, I mean, I always just find that helpful in general, but letting them know that we can write a doctor's note and that may not excuse you from work. And that like you deserve good care and you deserve to feel like this happened and I believe you. And that can be really re-triggering if your work is not doing that, but that's like a decision that you get to make. It would be very, very sad if someone thought that they could be excused from work from a doctor's note and they couldn't, and then ended up becoming more in a worse situation than they were already.
Absolutely, and that's a great point. And to add to that point too, it's really hard when our patients have that kind of trauma brain, and they may not hear everything that we tell them. So sometimes we may tell them that, and it's not processed, or they don't remember, and that can be really hard too, because we can talk till we're blue in the face, but if somebody is not prepared to receive that information, it's hard. It's really hard. So I love that we're our program does call all of our patients. We ask them, like, is it safe for us to call you in a few days? And we will call them and say, you know, do you have any other questions? Is there anything else that you're experiencing that we can provide you with support? Can we connect you with anybody? So we try to reach our patients as best as we can. Not everybody answers the phone or calls us back, but you know, if they do have some pressing needs, they often do. And we've saved people's lives just through that. We had somebody who had a very sensitive gunshot wound and didn't really have, you know, the medical knowledge. And he said, well, I'm having all these symptoms and my family is, you know, taking care of this wound and this is what it looks like. And we were like, oh, no, you need to see somebody like right away, because he was near septic. And we found somebody else who had a broken leg and was developing compartment syndrome. So, you know, it's stuff that we never thought that we would catch, that we're just catching by calling our patients.
That's great. Great that you are establishing that relationship where folks feel comfortable enough to reach out later, because that's not always the case. So I love that. Another question we had was victim compensation. So does that require a police report? And I know now that there's been some changes within the law that allows folks to apply for victim compensation to help cover some of those costs without having to then file the police report. But correct me if I'm wrong on that.
Well, that's only for victims of strangulation.
Okay.
So, so for sexual assaults, somebody could get have funds through the SAVE program if they are a medical or anonymous reporter. To have victims compensation, you do have to be a law reporter for all crimes, except for this new law with strangulation. So with strangulation, you can submit for victim compensation if you do not file a police report. My issue with that is that a lot of patients that we see don't report strangulation. So it's leaving this huge gap between survivors of intimate partner violence who were strangled and were not strangled. So if a patient was never strangled and they're in a very dangerous situation and they need funds to get out and they're too scared to you know, make a police report, then it's really terrible that we're doing those survivors a disservice by not allowing for victim compensation. So I hope that does change, but right now they do have to file a report.
And there's also comment that I read in our victim compensation brochures that they have to report to law enforcement within 72 hours, which also does not leave a lot of time for patients to decide on whether or not they want to file that report.
Yes, there are
Absolutely.
a lot of restrictions around victim compensation.
Yeah. Are there any resources that you or anyone else here is aware of that help pay for some of those bills associated with the SANE exam or FNE exam? if someone chooses not to participate in that process?
So I always recommend calling our billing department and speaking with them. So I just had somebody call last week and say that they had gotten a bill and they weren't sure if they were eligible for victim compensation. So unfortunately, our office does not deal directly with any of the billing or funding or anything like that. So we do have to have them call our billing department.
And I will tell you that victim compensation does that too. So they are like always negotiating some of those fees and payments as well. So I absolutely advocate for folks that I work with to do the same thing. Call and advocate for yourself. If you need support, I can help you with that. I don't specifically know of any nonprofits that deal specifically with repayment of these kind of funds, but I know there are ways. You just have to be really creative. If there's any more questions, feel free to put that in the chat. Otherwise, feel free to contact Loretta or myself. Our contact information is here, and the QR code that's here is going to take you directly to our website. So
I will
thanks
reshare
everyone.
that.
Yeah, it's been up for a while. You're fine. So thanks everyone for being here, and thank you, Loretta, for all of your amazing information and the work you do.
Thank you for having me. It's been a pleasure chatting with all of you.
Absolutely. All right, everyone, have a great Wednesday. Stop recording.